3 weeks out, the Affordable Care Act webpage project rollout is in a state of failure. This assertion will be thoroughly discussed in the context of the project, the root cause problem, consequential outcomes, a professional management way forward, and what it means to take a calculated risk. Driven by over-politicized decision-making throughout, the ACA webpage project has been a supply chain failure, quashed by heavy-handed senior management, both government and its Canadian contractor. The voices of the technical staff went unheard. It is no wonder that technical staff members are getting sick and fainting at meetings. Even a woman on the podium behind President Obama in his October 21, 2013 speech defending the ACA webpage project rollout also began to faint as she dutifully fulfilled her role as a prop in the charade. All that and the flagrant act of software piracy in removing the copyright notice and credit attributions from the open source code used. Software projects that launch this poorly with so much commotion do not end well. This project, like other failed projects before it, cannot be rescued simply by working as hard as they can 24/7 to detect and correct bugs as they appear. Instead, its deep-rooted problems must be ferreted out, identified, acknowledged, findings assessed, and recommendations framed and acted upon. A 60-day effort to do this should begin immediately. The ACA website is a software-based facility intended to bring customers and health care providers together. The purpose of this software is to ensure harmonious cooperation between people and machines in enrolling customers in affordable health care plans that meet their needs. The ACA website rollout has demonstrated that it is incapable of achieving this primary purpose, that is, bringing customers and healthcare providers together in a harmonious and satisfactory relationship. For the past 3 weeks, the ACA website has been operating in a state of failure. The ACA website has not met the standard of excellence, either expected or promised, of best industry practices. It is not complete. It is not correct. It is not consistent. And it does not follow the rules of construction for an industrial-strength healthcare application architecture. Operating as a supply chain, the mission of the ACA website is to permit customers to apply for and purchase affordable healthcare, to comparison shop, to enter profile data, personal data, and decision data, and to facilitate healthcare providers to promote their offerings, provide product pricing, and accept and confirm customer decisions, including changes in decisions. There have been reported problems at every step in the ACA supply chain flow. We know this because the first 3 weeks saw 19 million ACA web page hits and only 473,000 applications. That is, customer-entered profiles and personal data. Just how many of these were paper applications, the recommended approach by navigators when customers desperate for insurance are faced with persistent web page difficulties? No small task. Supply chains are risky and complex operations. With 55 companies delivering products, components, services, and relationships, the ACA website connects to a variety of other government systems, including Social Security Administration, Internal Revenue Service, Veterans Administration, and the Office of Personnel Management. Not just English, the ACA website is intended to support Spanish. However, this feature is currently on hold. Over-politicized decision-making appears to be the root of the problem. First, there was the decision to select a Canadian contractor who encountered similar difficulties in a failed healthcare project in Ottawa. Then there was a decision to finesse the potential for public problems prior to the 2012 election by postponing the start of the ACA website development effort. With specifications appearing only in early 2013, followed by the start of code development. In an effort to retain control and contain problems, the government decided to serve as the project integrator. Instead of tapping the expertise of an industry technology integrator like IBM, the government decided instead to retain its own Centers for Medicaid and Medicare Services, CMS. Instead of providing a simple and free flow of healthcare product and price information to customers, it decided to reveal pricing information coupled with the determination of subsidies so as to avoid expected sticker shock by customers if presented with actual market rates. Instead of the requisite 4 to 6 months of testing, the government decided to neglect that testing by delaying its start until 4 to 6 weeks before the rollout date of October 1st, 2013, and only then deciding to finalize project requirements, a decision which further delayed the start of testing until 4 to 6 days before the rollout. As a result, the outcomes have been consequential, characterized by gaps, defects, complexity, and growing technical debt as problems are encountered faster than they are corrected. Confidence in the old-style architecture of the ACA website has been eroded with each new revelation. Not yet in evidence, but on the forefront of every technical practitioner, is the deep-seated concern over cybersecurity risks that arise whenever projects encounter difficulty. Architecture is questioned. Evidence of poor practice abounds. Lack of evidence of software assurance and risk management are to be found. And extreme politicalization of decision-making and heavy-duty senior management intervention are the rule. Those pretending that the problems being encountered are glitches, kinks, or simply bugs to be fixed, and hoping that the problems will simply dissipate with the not-so-reassuring 24/7 effort being expended, need to cease their wishful thinking. Instead, everyone needs to insist on the professional management steps needed to get to the bottom of this and right the ship. The following 10 steps are called for immediately. Number 1. Use of ACA website by customers seeking health care insurance should be terminated. Number 2. Existing customer profile data, personal data, and decision data should be quarantined. Number 3. The ACA website requirements foundation and the technical architecture should be reviewed, assessed, and audited by a team of experienced industry experts. Number 4. The management, engineering, and process practices employed on the project should be reviewed, assessed, and audited by a team of experienced industry experts. Number 5. The accumulated technical debt on the project should be reviewed, assessed, and audited by a team of experienced industry experts. Number 6. A professional team should be charged with assembling factual analytics associated with assurance metrics, compliance metrics, non-compliance metrics, product engineering metrics, project metrics, and process metrics. Number 7. A full-scale program review should be conducted to assess requirements, architecture, practices, and metrics. The review team should record its findings and consequences and provide recommendations and rationale for carrying out the project forward. Number 8. A professional team should be charged with assessing cybersecurity vulnerabilities in accordance with the NIST cyber framework. Number 9. A professional team should be charged with assessing privacy and civil liberties vulnerabilities in accordance with the NIST cyber framework. Number 10. The completion date for these activities should be established as December 16th, 2013. The job now is to take a calculated risk and not continue with the crapshoot. Just how is a calculated risk determined? The goal is to enroll 7 million people in affordable health care by March 2014. The ACA webpage is the means chosen to accomplish the goal. However, the webpage has proven to be a problem, and a timely remedy to the webpage as currently construed is unlikely. The webpage application costs are approaching $500 million, with 55 companies now on the job. Continuing on this tech surge path may raise the cost to $1 billion or more. In his October 21, 2013 speech on the ACA webpage project, President Obama acknowledged the problems with the webpage and encouraged people to use telephonic or paper applications if they encounter web difficulties. So one alternative to achieving the goal to enroll 7 million people is manual by phone at the number given, and paper. At a productivity rate of 1,000 applicant signups per year per navigator, with a burdened annual cost of $250,000 each, the estimated cost for manually enrolling 7 million people might reach $2 billion. So the available options are: number one, to proceed on the current course and hope it works out, perhaps a cost of $1 billion. To take the professional management steps needed to get to the bottom of this and right the ship, perhaps $1,500 million. To employ the manual, telephonic, and paper application method, $2 billion. The risk management decision is whether to select one option and proceed, that is, the $2 million maximum, select two options and proceed in parallel, $3.4 billion max, or to select all three options and proceed in parallel, $4.5 million. Here is my contact information. I would be happy to receive questions and have discussions with people on this important subject.